definition is not exactly there. Then neck pain with headaches, cervicogenic headache. Then neck pain with radiating pain, radicular neck pain. So in each of the categories, neck pain can be acute, subacute, or chronic. But for the purpose of our presentation, we are limiting ourselves to the acute. And where the definition of the acute did not capture the subacute, then we may take in the acute and subacute. So the duration of 1 day up to 12 weeks is what our presentation is taking care of. So why is your patient in pain? When your patient comes to the clinic and then there is pain around the neck region, why is that patient is in pain? When a clinician sees a patient with neck pain, the first thought will probably be, is there any underlying sinister cause of this patient's neck pain? So most of the times when we see patients, we are thinking that there is a pathology. There must be something wrong with the biology of the neck. And then that is giving our patient pain in the neck region. In acute painful condition, this is understandable. But if we are dealing with chronic pain conditions, sometimes we have to be very careful because patients may present with serious pain, but probably there is no attributable biological pathology with the patient. There can be pain without any pathology. But in most of the acute conditions, since we are talking about acute neck pain, then it is good that we check and see if there is any pathology related to the patient. So in the emergency care, the serious underlying concern is fracture, dislocation, or other structural injury requiring special care and or surgical correction. So mostly in our Nigerian practice, we hardly find physiotherapists practicing in the emergency care, but sometimes physiotherapists are having referrals from the emergency care that they have to go and attend to patients. So if there are such kind of patients with emergency presentation regarding pain in the neck region, then the most important thing is to first establish what is wrong with the patient before managing. Physiotherapists have a lot of manual intervention, and there are a lot of red flags to our manual interventions. So we have to make sure that this patient is not in fracture. So there are established imaging techniques to see the integrity of the vertebrae around the neck region. Is any of the cervical vertebra fractured or not? Is any of them dislocated? Or maybe there are serious muscular or nerve injuries around the neck region. Fracture or instability may also be of concern in a patient without acute traumatic onset, but with association with other conditions such as cancer. There has not been serious, maybe trauma to the patient, but from the medical history, this patient probably maybe has been battling with cancer or serious infection or systemic diseases, maybe inflammatory also arthritis or other neurological compromise. So because of this, a little trauma may also end up making your patient to have cervical fracture. So there is need for you to make sure that this patient has been properly investigated for these traumas, and then to see if maybe the integrity of the C-spine is intact, or there are other pathologies that may require referral to other professionals to manage the patient. So in the context of the neck pain task force mandate, evaluating neck pain without serious underlying structural disease, the next clinical question is, what is the problem and what is this patient's likely prognosis? For example, it may be the problem of the patient is just muscular, usually muscular presentations. They may be like maybe trigger points in the muscles. And sometimes with just one manual intervention to the trigger point, the patient has completely recovered. So you have to also take into consideration this is a condition that perhaps I am going to have 100% recovery within maybe few days, or this is a condition that probably will have to take maybe sometimes. Acute neck pain, for example, that is immediately presenting with probably maybe radiculopathy, then perhaps when you start managing the patient, maybe it will take some time for you to have centralization of the pain from being a referred pain and now making it localized to only the center, and then now trying to completely eliminate the pain. So at this point, the clinician may or may not order further diagnostic testing based on the presentation of the patient. If you are not suspecting any serious pathology, then probably you will go ahead to now examine your patient and then plan management. But if there are those serious alarms, red flags, then there will be need for diagnostic testings before you go ahead with the examination of your patient. So as I have previously, in the previous slide discussed, that we need to revise the anatomy and see the structures. And then while noting the structures, so superficially, when we look at the muscles, for example, when we look here over the trapezius muscle, is the biggest superficial muscle that covers around the neck region. I can see my internet is. Can you hear me, participants?
Yes, we can.
Oh, okay. So trapezius covers the rectangle of the neck. So in the definition that we said, from the medial margin of the scapula, then to the superior nuchal line, and coming down to the C7 spine on the left and on the right. So all that region is considered to be the neck region. So pain around that region is neck pain. So many of the patients that we have, probably maybe the occupation they have or the posture they assume while sleeping, while walking, then it makes the muscle to be in a contracted and tightened position. And because of that contraction and tightness, then the muscles may develop palpable nodules there, which we call trigger points. And then there will be acute, serious pain that will limit the movement of the neck. And then the patient is unable to properly turn or flex or side flex the neck. And the patient may come to the clinic. And mostly in this, since it is an injury with the muscle needs to be manually treated. If the muscle is not manually treated, the patient will continue to be in the pain. But if it is manually treated, because the muscle is the one that has the issue, then the patient will get much better within a very short period of time. So the muscles need to be examined, usually by palpation, by stretching. If the symptoms are getting worse, then the muscle under investigation is one of the causes of the patient's symptoms. While if we look at the vertebrae also, the intervertebral spaces we have that allow the movements in the anterior-posterior direction, in the lateral directions, we have ligaments that are keeping these vertebrae together. So when we try to destabilize any of the vertebrae and we localize the vertebrae and we try to destabilize the joint, then there are maybe reproduction of the symptoms, or the symptoms are getting worse. Then that specific joint may be contributing to the symptom of the patient, and there may be need for the therapist to also treat the joint. So it's not just having the symptoms of the patient, we need to also examine the structures and see if there are symptoms reproduction or ease of the symptoms from examining those structures. And then the vessels that also pass through these structures, especially the arteries that are supplying the head, the brain, and other structures. So they pass through this foramina of the vertebrae. And if there are insufficiency related to these vessels, then there may be also symptoms of pain in the neck and in the head region. The difference is that typical pain from the muscles and the bones are usually localized. In the worst scenario, you have referred pain to the upper limbs. But when there are vascular affectations, then systemic symptoms like maybe dizziness, fatigue are usually associated. So that is why a physiotherapist, while taking the history from the patient, if there are such histories of getting dizzy, getting head fatigue, headache, then there is need to also examine and rule out that these vessels are intact. There are no insufficiencies related to them. So usually, when they are compressed along the foramina they passed, when, for example, the vessel is on the left side and then there is side flexion on the left and then there is rotation, then usually the vessels are twisted and they are narrowed down. And if there is reproduction of the symptoms and then presentation of the dizziness, headache, then this is a serious presentation that probably there are insufficiency in the vasculature, and manual therapy and manual examination is usually contraindicated because there may be blockade of blood supply to the brain while you are manually examining the patient or manually treating the patient, which may end up with serious problem with the brain. So all this need to be taken care of. And then the nerves, usually we all know the nerves, we have the cranial nerves, then we have the brachial plexus. So if the nerve roots are also examined and while trying to compress them, there are reproduction of the symptoms, then it is a sign that these nerves are also contributing to the pain of the patient. And we know when nerves are compressed, one of the aims is those nerves should be decompressed. And usually we decompress them usually by distracting, where probably maybe we have to give traction or we have to strengthen the muscles if there are weaknesses of the muscles, so that those muscles that are weak, that are allowing maybe the vertebrae to now collapse over the nerves, will now be strong enough to sustain the weight of the structures without allowing the bones to compress on the nerves. So what are the possible causes of pain and or limitation of movement in the neck region when you see your patient? Usually trauma is the most common one. Many of our patients, they come with neck pain because of associated whiplash injury, where there is anterior-posterior movements during accidents, where the head has to move in this direction that makes the structures to be injured. Then sports and occupational injuries. Many individuals that are playing contact sports where opponents may hit a sport person around the neck region, or they may fall around that region. They end up with pain around the neck region. Then fracture of spinal body, spinous process, or transverse process. They are all associated with the trauma when someone sustained closed injury to the C-spine region, and it may end up fracturing any of the structures of the vertebra. Then ligamentous sprain, usually when the neck is sustained in a stretched position, maybe abnormal angle during the accident, the neck is twisted in an abnormal angle before someone will receive emergency first aid. Then those structures have been overstretched, and then the ligaments that are protecting the vertebrae, may sustain injuries. The muscular strain, usually poor ergonomic postures during the trauma or accident, or in the sports, usually maybe contact sports like boxing, kickboxing, and the rest, where the muscles are injured. Then degenerative changes may also be the cause, but usually degenerative changes, they are of gradual onset, so mostly not associated with acute neck pain. Then cervical rib may be a reason. Hypermobility syndrome, individuals that have hypermobility, then even though there are a lot of musculatures around the neck that gives it protection, but if they have hypermobility, then they are usually associated with neck pain. It is good that when we are examining our patients, because most of these manual therapies, we work within the anatomical range in the neck region. But if individual is having hypermobility, you will go beyond the anatomical range, and then the patient may sustain serious injuries to the underlying structures. So it is good to examine the patient and know if the patient maybe has tendency to have hypermobility. Hafiz, we don't have a patient here, yes? Eh? A model, okay. Who is supposed to be the model? Oh, you are the model. Okay, are we having the camera to just indicate? We are trying to have a project to demonstrate how we now see the possibility of having hypermobility syndrome in patients. So before getting there, participants, now, if I'm suspecting probably maybe my patient may have hypermobility syndrome and is presenting with neck pain, should I examine the neck to see if the neck has tendency for hypermobility or not? Participants, I'm asking.
Please repeat the question.
Hypermobility is the absolute contraindication for manual therapy and manual examination of the neck. So if I'm suspecting probably this patient may have hypermobility, should I subject the neck to examination to see if the patient has hypermobility or not?
For an objective evaluation, I believe that you may still have to, but you can be mindful of the fact. But if you don't go through any range of motion, then you may have nothing to document, unless maybe during the subjective you were observing other things. But I would say you would still have to go through some sort of active range of motion, being mindful that there might be hypermobility.
Okay, thank you very much for this constructive contribution. So usually when we have the patients, are you ready? Uh, yeah. Okay. Okay. So when you are suspecting that the patient probably has hypomy. Khadija. Okay, please come. This one is back. Okay, so I can continue. Yes. But ask a question now. Let them know. Okay, are they with us? Are you with us? Can you hear us?
Yes, yes.
Yes, sir. We can
Can
hear,
you
sir.
hear us?
Yes, sir.
Yeah.
Can you see the video?
No, we can't see video.
Èyí náà hàn kí ṣe ẹjọ́ ọ̀sẹ̀. Ó jọ kú èrè àjà. Àwọn ṣì tí ó ń
Can't see you.
Yes, I can hear you.
Oh boy, you can sleep. Oh.
Hello, sir. I can hear you.
Can't hear you, Oga. Can't hear you.
I can't
Hello.
hear you, sir.
Please, what's happening? We're not hearing anything.
Hello, sir. We can't hear anything, please.
Yeah, it seems we lost the center. Yeah.
I think I agree. Maybe we should continue with the presentation. When we are done, we can now do the practicals. Thank you. Hello, can someone please address us? What is happening? It's taking a long time. We want to know, please.
Hello?
Hello.
Yes, can we continue?
Yes, sir.
It seems the network is so bad that even the demonstration, when we try to make the video, is not connecting us. Is your own working? Can we make it link now? So when we suspect the patient with neck pain to have instability, so it is not recommended that you now go ahead and examine the neck for instability. There are specific tests that are used for examining neck for instability, but it is highly discouraged that if you are not specifically trained to administer those tests, you shouldn't administer them. But on a general, there are tests that are used to know if this person has joint hypermobility or not. So like using the Brighton and Baton scoring, where you use peripheral joints to know if on a general anatomical structure, this patient or this person has hypermobility of his joints or not. Hello, participants.
Hello, sir.
Oh, it is a pity that this internet is not allowing us to have a very good
Yes, sir,
session.
we can hear you, but it's like you're having a network problem. It comes on and off, and I think we're
Yes,
losing
that is the problem here. I'm at the Ray Institute, but
I know,
unfortunately,
sir,
the
it's
internet
really
connection.
making it so frustrating to enjoy the topic, how interesting this topic is, but this network thing is really causing.
Yes, that is the problem. And that is why I didn't even sit at home to make the presentation, because I know I will not trust my internet also. But unfortunately, also, they are using a modem, but it's still not giving us good internet. It's like both MTN and Airtel, their network today maybe is not so good. Perhaps here in Kano. But if for now maybe we can hear ourselves, then I continue.
Yes, sir, but we can hear you, we can see your slide. Maybe we can continue with that, sir. We can hear you, we can see your slide. Maybe we can
Okay,
just
so
continue with the presentation
if
if
you
you
are
don't mind, sir.
suspecting, probably maybe the patient may. Yes. So we can examine on a general note to see if this patient has tendency for joint hypermobility or not. I was describing Brighton and Baton scoring. Was the thumb, the knees, the elbows are used to examine if patient has joint hypermobility or not. The little finger is examined by extending it. If it can extend beyond 90 degrees, then you will say you are scoring your patient 1 already, that is the right. Then you examine the left also. If it can go beyond 90 degrees, then that is 2. Then you come to the thumb. If it can reach the anterior surface of the forearm, the flexor surface, then it is another score for the right. Then you also examine for the left for your patient. If it can touch the anterior compartment of the forearm, it is another score. Then you go to the elbow. You try to extend the elbow of the patient. Is there hyperextension of the elbow? Is the hyperextension up to 5 to 10 degrees for the right? Then you also check for the knees, the right and the left. Is there hyperextension of up to 5 to 10 degrees? Then after that, then you now try to ask your patient to reach ground with the palm. While standing, they now have to go and flex and then try to touch the surface of the floor with their palm, not with the tip of their fingers, with the palm. If they're able to touch it, then it is another score. So if you count the 2 little fingers, we have 2. Then the thumbs, 4. The elbows, 6. The 2 knees, 8. And then reaching ground, 9. So usually, for men, those that have 4 and above, you now tag them as individuals with hypermobility. While for women, because they have joint laxity from 5 and above. So if an individual, by this examination of the superficial joints, is within the category of the hypermobility, then those hypermobile tests for neck region should not be conducted, because there is tendency that this person has hypermobility, and when you are moving their neck region, then they may go beyond the interfere with neurovascular bundles around the region. Okay, I should repeat the examination.
Yes, sir.
Yes, I said you examine the patient. So instead of going to the neck to make the examination of hypermobility in the neck is only recommended if someone has had a specific training on it, because it is an examination that, if wrongly done, within a very short period of time, a patient can lose his life. So because of that, the general superficial joints hypermobility test is recommended. And if a patient falls within the range of hypermobile individuals, then such examinations should not be conducted in the neck, and also interventions that require thrusts and movements like manual therapy that have to give manual thrust to the neck region should not be conducted. So you use the little fingers, left and right. So each little finger now, you try to now extend it. If it can extend beyond 90 degrees, then it is 1 score out of 9. Then you also examine the left. If it can go beyond 90 degrees, it is another 1 score out of 9. Then you come to the thumb. You try to flex the thumb to touch the anterior compartment of the forearm. If it is able to touch it, it is another score out of 9 for the right. Then you also come for the left. You try to reach. Sometimes when I'm examining women, I may get 8, 7 over 9. Those that have such hypermobility. Even in traction, usually it is discouraged that someone with hypermobility to receive traction, because you are only allowed to distract your patient within the physiological range. While those with hypermobile joints, when you now try to distract, then it can go beyond the anatomical range, and then you will injure other structures, you will stretch neurovascular bundles, and then you will end up harming the patient. So when you try with the little fingers, the 2 of them, then the thumbs, trying to reach to the anterior compartment of the forearm. Then you now come to the elbow. You ask your patient to extend the elbow fully. Is there hyperextension in the elbow? Is it up to 5 to 10 degrees? If yes, then it is another score out of 9. For the right, then you also check for the left. Then after that, then you now go for the knee. Ask the patient to fully extend the knee. Is there hyperextension of the knee up to 5 to 10 degrees? For the right, then for the left. Then after that, then you try to now ask your patient if the patient can now reach ground with the surface of the hands, not with the tip of the fingers. If the patient is able to reach the ground with the two palms on the surface, knee extended, then it is another score. So now, if you count, they are all in all 9. So for men, those that have up to 4, Hello?
We can hear you now.
Okay. So, have you all gotten the explanation of the procedure for the assessment of the joint hypermobility?
No, sir.
Can someone respond if maybe you are getting my voice or not?
Yes, we can hear you.
Okay. Okay, the last step. Okay. I said after you have finished making the assessment, so you have one finger here, making it 2, the thumb, making it 4, elbow and elbow, 6, knee and knee, 8, then reaching ground with the palm, 9. So out of the 9, for men, usually because they have less tendency for hypermobility, if they score up to 4 out of 9, they are considered to have joint hypermobility. But for women from 5 and above, then they are considered to have joint hypermobility. So individuals with joint hypermobility, for examination of the neck, it is discouraged that you use passive movement of the neck. Okay, I should repeat for the knee. For the knee joint, you assess your patient for extension of the knee. They fully extend the knee. If there is hyperextension, genital recurvatum, of up to 5 to 10 degrees, then it's positive in that specific knee. Then you examine the other knee also if there is hyperextension. So the 2 knees need to be examined. So when you finish examining, out of 9, how many did your patient get? If they fall within the range of individuals that have hypermobility, so passive examination of range of motion in the neck for accessory movements usually is discouraged, unless if someone is specifically trained on assessment of hypermobility in the neck. And those tests require specific training. Then also, if at the end we are reaching also where we will now see what is recommended for the management of patients. If the option you have, cervical traction, is among the option, but you have already examined your patient and the patient has tendency of hypermobility, then traction is also contraindicated because individuals with hypermobile neck, because other structures may be injured because the joint can go beyond physiological range. Are we together?
Yes, we are.
Yes, we are together, sir.
Sir, I missed the counting, sir.
Okay, for the counting, I said, all in all, you have 9 assessments. 2 for the little finger, 2 for the thumb, 2 for the elbow, 2 for the knees, and then 1 for the palm reaching the surface of the ground, which is 9. So for men, 4 out of 9 is considered hypermobile, while for women, 5 out of 9 is considered hypermobile. So any patient that has hypermobile joints, then assessment of accessory and passive movements in the neck are contraindicated, except if you are well trained to administer specific neck hypermobility assessment tests. Also, if traction is among your treatment options, individuals with hypermobile joints, they may have soft tissue injuries while receiving traction because the joints can go beyond physiological range. I hope it is clear. So among the possible causes also cardiovascular diseases. And in this one, we said it is also recommended that you examine the patient if dizziness and others. So if the patient is having symptoms aggravated by that, then probably it is not pure neck pain, but there are cardiovascular implications. Then inflammatory conditions, signs of inflammation around the neck region. If there is an ongoing inflammation, you examine. Then individuals with rheumatoid arthritis, they may end up also with the neck pain. Other investigations of the smaller joints to see if there are deformities related to investigations. Probably maybe if there is need for checking to see if maybe there are rheumatoid factors and others is also needed. Then ankylosing spondylitis, if maybe there is early signs of ankylosing spondylitis where such passive movements also are discouraged, then a person needs to be sure of that while examining the patient. Then there may be also issue with individuals with infection, cancer, also pain in the neck region associated with Rhineck torticollis. And then many individuals, the headache they have, you have to check, maybe it is associated also with presentation in the neck. It is specific headache or cervicogenic headache. Migraine may be associated with symptoms in the neck, tension type headache, and then cluster headache. So after that, then we need to examine and see where our patient have the symptoms in the posterior neck, in the lateral neck, and then in the anterior neck. Usually, patients that are able to easily pinpoint where they have their neck is simpler to manage, and usually the pain is sharp and maybe from muscular origin, while some individuals will just give you the region. The pain is around this region, and it is in the clinic. Maybe you have the chart so that you can indicate while you initially assess your patient where they have the presentation. You have to tick where the symptoms are around the region, so that as you are managing the patient, when you use the chart again, you will see if the patient's pain is spreading more or it is narrowing down to a centralized position. And then you also consider other components of your patient's assessment. What age is the patient? Individuals that are of advanced age, you may have to be careful with the examination, the integrity of the musculature, the musculoskeletal structures must have aged, their integrity is going down. So the rate at which you can move the joint, you can stretch, is an issue. Then gender, just like I explained the hypermobility. So usually women have tendency for their joints to be hypermobile than men. Then ethnicity. Sometimes when you are rating the pain, it depends with the ethnic group of the patients. Some have tendency to exaggerate pain, and some have tendency to hide pain. You have to try as much as possible to get the exact pain the patient is having. If the patient is hiding pain, you have to explain that this is where you need to know the level of the pain and appropriately manage the pain. Hiding the level of the pain in the society, it may be something good, but in the clinic, it's not something good. We need to know the exact pain score of the patient. Then cultural and social background. We need to know if there are some expectations related to the patient. If probably maybe there are some interventions that when you give, because of the position of the patient in the society, perhaps the patient may not adhere to such interventions. And then the occupation, what is the relationship of the patient's presentation with his or her occupation? Is he the type that probably maybe will be afraid of losing his job if this intervention and the treatment will take longer time? Or he is the type that probably now he is pretending, want to show that he has serious pain and presentation so that he will be off work for very long time, not like in the private sector, probably where he'll be afraid of losing job, while some in the public, they would want, can you please mark my pain to be so serious that they will give me 1 month off, they will give me 2 weeks off. So all this need to be adequately investigated while interacting with the patient to get their attitudes and their feelings on that. Then area of current symptoms. They have, the examiners have to be very exact while mapping out the area of the symptom. Where and where, that is why using the chart is very essential. So you have the chart, now you're examining the posterior aspect of the neck. Then on your chart, okay, tell me where and where do you have your pain? And then you have to be mapping out the pain. And if there are areas where the pain is more intense, while mapping out where the patient's pain is more severe. Patients with upper cervical spine disorders have neck pain high up around the occiput and pain over the head and or face. So if there are presentations around the head and the face, then you will suspect that the disorder is more of the upper cervical region. So if you are going to give manual therapy, then upper cervical region need to be manipulated. If it is indicated for maybe traction, then upper cervical region need to be distracted. Ascertain the worst symptoms and record where the patient feels the symptoms are coming from. Then you have to examine and see the worst pain, and then also have the patient's perspective. Where do you think your pain is coming from? Some they will have negative perspective, which will now end up giving them fear and avoidance. And if you have not also addressed the fear and the avoidance that the patient have, then they will continue to have serious problems. That is why we also have outcome measures that have to measure the fear the patient is having, and then other related things. So we check symptoms around the head. Is the patient having head symptoms? I said usually if there are head symptoms, usually they are associated with upper cervical problems. Then teeth. Usually there are pains that can radiate to any of the teeth, and then pain also in the dentine region may also radiate to the neck. So such examinations need to be. Then temporomandibular joint is also sometimes mimicking the neck pain, so it needs to be examined. Then thoracic spine, sometimes we may mistake the pain that is of lower cervical origin with that of upper thoracic region. Then we have to examine the shoulder, elbow, and the wrist in case there are symptoms of radiation. If there are symptoms of radiation, we know that there is possibility of the nerve roots or along the course of the nerve getting compressed. Then this equilibrium and dizziness. I have explained the cervical arterial dysfunction. If the patient is having such symptoms, then probably maybe there is insufficiency of the blood supply to the brain region. You need to examine. And if the assessment is positive, then the patient needs to be referred, because this is also a red flag. So for pain, we need to assess the pain, the quality of the pain. Is the pain dull? Is it aching? Is it pinpointed? If there is headache, examine. Okay, the patient is having headache. Is the ear, auditory disturbance? You measure all that. You ask for all those information to tell you if there are other central systemic presentation. The intensity of the pain. It is always recommended that we assess the intensity, even though most of our colleagues in the conventional practice hardly make such a rating, but it always makes sense that you rate the pain intensity of the patient so that as the patient is receiving intervention, is he getting better or not? And not just the intensity, also the characteristic of the pain. The pain may be intense, but it only comes maybe once in a day. And other patients probably maybe they have the symptom all the day time, while some, the frequency at which the pain will come and go, maybe like 10 times, 12 times. So even if you have not been able to, for example, substantially reduce the intensity of the pain, but the frequency have greatly reduced, symptoms coming up maybe 10 times in a day. Now they only have them maybe at sleeping. When you have recorded all these characteristics, they are getting better or not. Then depth of the pain. Some pains may be superficial, some may be deeply situated. And when pain is deeply situated, then it is indicative of maybe inner structures, while superficial may be associated with the superficial structures like the muscles. Then abnormal sensations associated with the pain, then constant or intermittent symptoms, then relationship of symptoms with other activities. When the patient does this, it gets worse. When the patient does this, it gets better. So the aggravating factors, usually aggravating factors are telling you maybe structures at fault or etiologies. So if someone, while flexing the neck, it gets worse, then it means the structures that are getting distracted while flexing the neck, they may be under trouble. While the structures that are getting relaxed while flexing the neck, they are not under trouble. So you have to get that. Is the patient able to maintain the position or movement while making the examination? Then what happened to other symptoms when the patient symptoms is produced? How long does the symptom takes to ease after the movement? When you now examine the patient, you have flexed the neck to see if there is symptom or not. How long does it take when you return the neck back to neutral position for the pain that got worse to disappear? So that tells you also how much pathological is the structure. If the structure has been affected so much, a little stretch of the structure will make the pain to persist for a longer time. How symptoms affect functions at rest and while being active, especially those that are working, when they are executing their job. How is the symptom when they are working? Do they forget about the pain till when they come up and sit at rest? Then that may be associated with hypersensitivity. When you have other activities that are masking
Hello? Hello? So let's have break for now. So that before we go back on the break, the internet would be. Let's have a break now so that we can come back by 2. 2 o'clock.
Hello, participants.
Hello, sir.
Yes, okay. I hope the internet now is better after I restarted. So we said we are resuming back at 2 p.m. and it is already time. So we will continue with the training. So while also documenting the information related to the symptom of the patient, it is expected that the physiotherapist is going to document the night and the day symptoms. The night symptoms, the issue of sleep, most of the times when we are managing our patients, only a few are taken into consideration the sleep issues. And some, even if they document them, they hardly use an outcome measure to see maybe, to use maybe sleep quality questionnaire or any sleep quality tool to assess their sleep quality and see as intervention is going on, how is the sleep quality? Is it getting better or is it getting worse? So we need to document this. Is the patient finding it difficult to get asleep? And what position is comfortable and uncomfortable for the patient for them to fall asleep? Then what is their normal sleeping position? Some of this will give us insight for the difficulty of sleep. We want to know if maybe the position they are assuming is the position that is making them uncomfortable. I have had a number of patients. That is why in the previous slides, I also mentioned the issue of the religion, the issue of the culture, need to really be discussed and documented with the patient. For example, I don't know for other cultures, most of the typical Hausa Islamic culture, when someone is going to sleep, it is recommended that they sleep on the right side using sideline position. But the position they use sometimes, if there are symptoms around the lateral side of the neck on the right side, and probably maybe the muscles there are tensed and they are painful. So the more you use that posture to sleep on the position, the more you make the muscles tensed. So individuals will now have to have the discussion that because of this is how the muscles are tensed. The muscles need to be stretched, need to be made soft. So for a while, you have to change your sleeping position to an alternative position so that these muscles will not be contracted more, and then the muscles will get relieved, and then the symptoms will get better. So we need to have this discussion with our patients. And also, if the night, how many So if someone is getting those symptoms in the past week, in the past days, how are the symptoms? We need to document them. All these are going to give us guidance regarding the outcome of it often contributes to the development of neck pain. So we need to ask the type of mattress and then the type of pillow our patients are using. Is it the type of pillow that will make the neck to always be in a flexed posture, thereby stretching the extensors, and then symptoms will be present while the plexus are getting contracted and the extensors are getting overstretched? And which type of mattress the patient Okay, still the network is still misbehaving. So then we come back also to the morning and evening symptoms. What is the nature of the symptom at early morning, through the day, and end of the day? What happens? Is it only early in the morning that the patient gets the symptoms, and as the patient gets more active in the day, then the symptoms get better? Or is it that the symptoms are much better in the morning, meaning that after night relaxation, then the symptoms get better, but as person gets active through the day, then the symptoms are getting worse? So we need to know now the relationship between the symptom and activity. So rest makes it better or rest makes it worse? Activity makes it better or activity makes it worse? Then, is there early stiffness, early morning stiffness in the neck, which may suggest maybe early development of degenerative changes in the neck? And then stiffness and pain for few hours that may be related to rheumatoid arthritis. And then through the days also, what is the relationship between the pain in the neck and the job someone is doing? Probably maybe there are poor job or occupational ergonomics. Someone may think probably maybe immediately he starts working, the pain gets worse. Those that have high tendency for negative beliefs, they may start thinking probably maybe someone is after their job or something like that, because it is when they start the job that it gets worse. But when they are at rest, the pain is not there. Then they will start relating it to spiritual things, when in the actual sense, the position they assume doing the job is what is now predisposing and provoking the pain. Probably the muscles or the joints are getting compressed or stretched, and immediately you now noticed the position they assume and you correct it, they will start getting better. Is it working there? The slide is not moving.
It's open. Yeah, it's moving.
This is their own facility, so I have to bring myself to the So as I'm explaining, the problem of the internet is that I am here at the Ray Institute, their own clinic, where usually the workshops are facilitated, so that if there are need for practical aspect of the workshop, there are couches and there are volunteers. So I am here and we are using the different internet hotspots, the modem, but the internet is still not so good. So it is unfortunate that the internet is not giving us the best. So special questions need to be asked to identify certain precautions or contraindications to the physical examination and or treatment. Usually when you examine the patient, and examination usually makes the pain worse. So usually such movements are not supposed to be at the initial stage of your intervention, because it seems those movements are provoking the pain because they are implicating the structure at fault. So you have to manage the structure first till when the structure is better before you include activities that will now involve much activities of that structure. If flexion of the neck predisposes the pain, so it seems maybe the extensors are getting stretched or are getting destabilized. So then flexion exercises to the neck at the initial stage of the intervention should not be recommended unless when the patient is much better and then the extensors are much better now, then you now include flexion. Otherwise, repetitive movement of the provocators will now make the pain and the pathology worse. A clinician must differentiate between conditions that are suitable for conservative treatment when they are localized, and then systemic. If there are systemic conditions, then referral for medical practitioner intervention is needed. That is why all this information. So we need to isolate conditions that would require physiotherapy intervention, and then other conditions that would require the input of other experts. Then we need to refer them to such experts. Is the slide moving there? I think the network is back. So if there are need for referrals, then the physiotherapist need to refer the patient regarding this acute neck pain. Some of other special questions I have already mentioned the issue of the cervical arterial dysfunction. We need to test for it, and if it is present, there is positivity for it. We need to refer. Then upper cervical instability, also need for referral. What are the risk factors for cervical arterial dysfunction? Usually past medical history of trauma to the cervical region or the vessels, history of migraine type of headache, hypertension, hypercholesterolemia or hyperlipidemia, cardiac disease, vascular disease, diabetes mellitus. Slide is looking. Can you hear me?
Yes.
But my slides are not moving, yes? Always happy. So you need to come and respond to these comments.
Maybe you should look outside again.
Hello, participants. I'm also seeing the comments. I think more frustrated than the participants because for me to prepare the slides also make the day purposely for the workshop on the internet is not the best for us. I'm at the rate I personally for the cervical instability. History of trauma in the neck region may make the neck region to be unstable. Then congenital collagenous compromise is individuals that the deposition of the collagen that hardened the ligaments and the structures around the neck is affected. Then inflammatory arthritis of the joints. Then recent head, neck, or dental surgery may predispose individuals to the instability because usually during the procedures, the neck region have to be completely relaxed, and sometimes it has to be moved in different angles and different positions. So it may predispose someone to the instability. So early signs of upper cervical instability, extreme neck stiffness, usually because it can easily give way, then the individuals will always be in a stiff position and then the muscles So other signs like excessive need for external support all the time. The patient that has the acute neck pain would prefer to use maybe a cervical collar or has to use any support to protect the neck region. Then report of the neck giving way, feeling unstable, worsening and unpredictability of the symptoms. You have done all the best for the patient, and at any given time, then the pain will completely worsen without doing any activity, nothing. They are all early signs of upper cervical instability. Then report of repeated self-manipulation. They will feel that the neck has moved to a certain angle. They have to bring it back. All this So now coming back to the main history. So how long has this acute neck pain been? And how did this acute pain develop? Is it sudden, which may be from trauma, or slow onset, which may be a sign of degeneration or compression? Then known or unknown cause that provoked the onset of associated headache or not. Then change in patient's lifestyle in the recent time. Has the patient changed before the commencement symptoms? Then the relationship of the symptoms. Then the past medical history or the relevant medical history, details of any relevant medical history involving maybe C-spine and related areas. Was there any surgery, any traditional bone setting, manipulation, history of any previous attacks of the pain, maybe in the past, maybe the pain has come and disappeared. How many episodes, when, and in the previous episodes, how did it happen? What was the cause? For how long? And then the recovery. Probably maybe we may be dealing with maybe intermittent or recurrent neck pain, not really acute neck pain. No history of previous attack, history of episodes of stiffness in the cervical or thoracic region, maybe some early sign of cervical disorders. The patient left his job or occupation because of the pain, of the help to get from the physiotherapist. What is the patient's expectation? What he wants? The pain should disappear completely in the next 1 or 2 days, or he wants, if the pain is still going to be there, let it be bearable so that he can execute his work. Then response of employers, co-workers, family to the pain. Are they much worried? Are they blaming the patient that he always complains about pain? He is not taking good care of himself, and the rest. Coping strategy. Usually this one is when the pain has been there for a kind of long time, maybe some days, some weeks. If it is very new, the patient will start looking for how to relieve his or her pain. But after some times, the patient will start believing that the pain is becoming like part of himself. So let him develop a certain way to live with the pain. Is that coping strategy medically acceptable, or it's going to do more harm than good to the patient? So you need to know what they do to get relief. We have some patients that probably maybe they will say, maybe some little kids, they will ask them to step on their neck, to do this, to press or to twist their neck. And it gives them maybe some relief, which we know medically now they will predispose themselves to other bigger medical issues. Are they hoping to return to work, to business very soon? When? We need to have this documented so that we will now compare with our intervention. So plan of the physical examination. So at this stage, then the physiotherapist will now have hypothetical region that from the explanation he got from the patient, this may be where the pain is coming from. So the patient will now have plan of where and where to now physically examine. How should the physical exams be carried out? Will it be easy or hard to reproduce each symptom? Now in the examination, the main aim is in acute pain. If at that time the patient is coming to you, maybe there is no pain. So it's to now reproduce the pain. You want to move his or her structures, the joints. You want to palpate. You want to reproduce symptom that makes the patient to come to you. If the patient is already in pain by the time you are assessing the pain, now you want to see what aggravates the patient's pain and what relieves the patient's pain. So this will now tell you the structures that are affected. But will it be easy to now reproduce the pain? Sometimes while assessing the patient, because of the pain, if the pain is so severe, so intense, then you may not be able to finish all the examination at that time. The examination is expected to be conducted within the limit to which the patient can endure. Not that you have to go like in traditional bone setting, that you have to go to the extreme limit where patient will be in unbearable pain. Then combination of movements, is it possible? Because usually combination of movements tells you about structures that are affected deep inside, like the vessels, like the nerves. Usually simple unidirectional movement doesn't compress, for example, the vessels or the nerves. But usually when you combine, because they pass through different structures, so when you make a combination, like for example, the vessels, the arteries, when you now side flex and rotate, then there is tendency that you now compress the arteries that are supplying the head. But ordinary flexion or ordinary rotation usually doesn't compress it. Also the same thing with the nerve. So if brachial plexus is now compressed from its nerve roots or along the course of the individual nerves, a simple flexion, side flexion may not compress the nerves. But when you now combine, for example, on the on the ipsilateral side. So combination of movement, is it possible? Can the patient endure the combination of the movements or not? If there are restrictions to examination, you have to respect that. If there are severe symptoms, then you have to respect that. At this stage, probably maybe you are only interested in giving rescue analgesia. So treatment that will now relieve the pain to a bearable form. Then subsequently, you can now carry out the rest of the examination
Hello.
Sorry, he's trying to reconnect.
Okay. Okay.
I think I'm reconnected back. So for the observation, we need the informal observation, which you have not yet exposed the patient. Then the formal observation where you now expose the patient, you observe the posture of the neck. Then the muscle form, is there if any of the muscle contracted? Then the observation of the other soft tissues, is there any swelling? Then observation of the patient's attitude and feelings as it relates the subjective examination when he's flexing the neck, extending, side flexing, rotating, all these activities. Still, this one too is going to be okay. Can you now hear me? Yeah. Yes. Okay, so for the active physiological movements, so we need to check the quality of the movement. Is there clicking or joint noises while you freely move the neck through the range? Then how is the range of the motion? Is it full? Usually for flexion, the chin have to touch the Is it throughout the range that the pain is present? Or through the range there is a position of the pain being present and being absent? Like probably maybe there is compression where it is like an impingement. As you move, the structure is compressed, then there is symptom. As you move more, the structure is relieved, then there is no symptom. So you have range where probably maybe the muscle is tensed or is contracted. Then provocation of any muscle spasm. As you move the neck, is there any muscle spasm along the flexion, extension, side flexion, or rotation? My slides are put, but if you can hear me, can you hear me? Yeah.
I can hear.
Can you hear me? Hello? Yes. Okay. Then also for passive intervertebral examination, then the range of the motion, that is the quantity, then the quality through the range and the end fields of the specific segment. Although these examinations, the validity and the reliability of the concept has been challenged, but despite the variance, there is still continuing use of these techniques, and they help clinicians to establish diagnosis and manage their patients. So for the passive physiological movements, I mentioned that I said the position for the therapist and the patients, it can either be in standing while the patient is seated, like you can see in the first picture, where now the passive physiological movements for the flexion and extension is being conducted. The head is supported superiorly and under the chin, and then the neck is moved into the flexion and the extension, while the therapist is in standing position and the patient is seated. Or the patient is in supine line position, and then the neck is supported bilaterally using the hands, and then the vertebrae are usually isolated using the spinous processes, and then the therapist move the neck through different segments of the cervical vertebra to get the quality of the symptoms and then the relationship of the symptoms with the movements. Snags and nags are often used for assessment and for management. At this segment, we are doing it for the assessment. So the movements are done to see if there is an angle of rotation or angle of oscillation where pain is much better or pain is getting worse. It is often used in Mulligan, where now the angle where you get there is pain, then you try to now adjust the angle and then bring in additional movement and then move through the range. And if the pain is much better and the movement is improved, then you repeat such movements. Then after that, then you now come back to the normal angle, and then you allow the joint to move and see if the movement has improved without pain. So for the passive accessory movements, if the posterior segment has to be assessed in anterior posterior oscillation, so usually is used. We often do not have the facial perforation on the couch, where now the patient has to face down, and then the therapist will now use the So for the snacks, the sustained natural apophyseal glides, then the adjustment of the position on the spinal segment is combined with movement of the neck. While for the natural apophyseal glide, movement is not combined. It is only the gliding of the spinous process of the C spine that is used. So it is done to isolate if pain is at certain limits, usually from the C-spine to the spinous process of the second cervical spine, coming down to the third up to the seventh. So each spinous process is being examined, and then the movement along Hello? I'm actually, I'm not so connected. You must still. Hello?
Welcome back, sir.
Okay, you can hear me now?
Yes, we can hear you, sir.
Now? Can you hear me? Hello?
Hello, sir. We can hear you, sir.
Sir, we can hear you, sir.
Can you hear me?
Yes, sir.
Okay. So apart from now examining the range of motion, the active and the passive, then the muscles can be examined. Usually muscle strength is also very important because when the muscles of the neck are very weak, then they may predispose the neck to instability and weakness, instability and then consequently pain. So the muscle strength, the control, the muscle length can all be assessed. Sometimes dynamometers are used. If there are no dynamometers, then you can use other subjective ways of examining the muscle strength and then the muscle control in the neck. Can you hear me?
Yes.
Then the slide is not moving. Can you hear me there?
Yes, sir. We can hear you from here.
My slides are hooked here, so I'm unable to show you the next slides. Oh, the slides are moving from your side.
It's not moving here, sir.
It's very frustrating. Marcus, what do you suggest? Hmm? Haja is a physical participant. Oh? So you think we should just give the lecture only to her while you are recording, or what? Or they will complain that, but they have seen that since morning this is the same vicious cycle. Hello? Hello?
Hello, we can hear you, sir.
We can hear you, sir.
Okay, my slides are not moving. Maybe I should share the slide with someone and I will just be using it from my laptop. Should I?
Yes, sir.
I share
You
it?
can, you can send me
Maybe
the
in the
slide.
chat?
Let me share for you.
Yes, sir.
Okay.
Please send the slides.
I need to move my so that I should just share with you. Say that okay, you'll be moving the slides. So let me share with the admin here in the Ray Center. Okay, through Bluetooth or what? Email? Okay. May email them? Ya kamata. Kamar wancan presentation ɗin ma na taɓa. Hafiz? Okay, zan shiga. Nasir. Ah, Isaac. Isaac. Nasir. Mm-hmm. 68. 68. At Gmail. At Gmail. Oh.
Oh my goodness. Okay, Auntie Ngozi. Auntie Ngozi. Yeah, I wanted. What is the money here? Yes, thank you. I'm like,
Even if your
mm,
even if your husband stop being you,
mm,
take
mm,
it is a serious thing. Because if she transfers it to any of your children,
hey,
that could be another big problem.
it's true. I get well. I'm like it.
So why are they sleeping?
Mm, mm,
Because
ma-
have you any idea of this to this young person have in the know?
ụmụntakịrị na-aba otu.
Like
Not
even initiated.
yes, possess children.
What is an idea about it?
It's a honey shame.
Okay, I want an experience of it. Okay, me and my junior brother. I got to put my housemaid one small girl. So when I got to put they no serious about housemaid. I say, I say, on housemaid for how many children each? We can't get on the housemaid. That's what I think. I look everything you're supposed to do. See, as housewife.
Mute on mic uno. Mute on mic uno.
Either a boy and a girl put it there. I love a village. So one of my father's relation.
Is the network bad again? What's going on?
Yes, so breaking transmission.
Hello?
Hello, we can hear you. And we can see the slides.
We can hear you, sir. We can see the slides.
Okay, so then neurological tests for the brachial plexus and the nerves also need to be conducted. Usually this one, where the brachial plexus passes, then usually the roots or the cause is being stretched. So if the right aspect of the brachial plexus is going to be is used so that the angle of the neck is increased in the right. An increase in the angle will now stretch the root of the brachial plexus. Hello?
Yes, we are here. I can hear you, sir.
Okay. So for the neural dynamic test for the brachial plexus and the nerves that exit from the brachial plexus need to be examined. Usually it is through the stretch from the nerve root in the neck, usually by increasing the angle of the neck, and then depressing the shoulder joint where it passes, and then adducting so that in the axilla also the nerves are also being stretched. And then the bias of the ulnar, median, and radial nerve are conducted at the end, where the nerve is also being stretched. Symptoms will now indicate radiculopathy. And then when the stretch is relieved, a relief in the symptom will also confirm the presence of an implication of the radiculopathy. And usually this may recommend distraction or traction at the cervical region. There are individual patients that will come with emergency neck pain that may immediately need radiography without being physically examined because of the implications of physical examination at that stage. Usually there is a Canadian C-spine rule that is used where maybe if the patient is of high risk for mandates of radiography, then immediately the patient is not even being examined, will be sent for radiography. So I just put the rule so that participants can go through them and understand. The red flags, I also talk about them so that we will just move to the treatment. We have been talking about the examination. The range of motion also, intersegmental cervical spine motion can be assessed, then active range of motion, then inclinometer may be used to assess the range of motion. Muscle strength, I've also mentioned that. Then palpation for tender points and trigger points. This is very important because along the muscles of the neck, due to posture, poor ergonomics, these muscles around the neck, sternocleidomastoid, the trapezius, are very prone to having tender points. And many of the patients that come with acute pain, it is because these muscles have points of tenderness in them. And if we give only manual therapy exercises without addressing those tender points, the patient will still continue to perceive the pain in the neck region. So it is good to also assess if there are points of tenderness in the muscles around the neck. Then there are other tests that may be warranted if there is need for systemic assessment, the biomarkers in the blood, electrodiagnostics, nerve conduction, if there is need. But usually when the pain is persistent and advancing to chronic stage, these are more indicated. Imaging, if there is need, after those examination and the therapist is thinking that this is a joint issue or a bony issue, then there may be need for x-rays. But after examining, if maybe it is of muscular origin, then no need for going for x-rays and MRIs. Usually manual investigation and manual treatment will do well. Then there are self-assessment towards the end, maybe use of some tools that the therapist, the patient will now score himself regarding some of the outcomes and the complaints like the pain, the disability, where the therapist will now administer such investigations, the questionnaires to the patient, and the patient will now respond, and there will be scoring for that. They are very helpful where the patient can physically see this is what he responded to at the start of intervention, and towards the end of intervention, after maybe some few sessions, will now also respond differently. And then that can be used to see if the patient is getting better or not. There are a lot of self-assessment questionnaires, like questionnaires related to pain. It can be pain intensity, it can be pain severity, then functions, disability, psychosocial status. Usually psychosocial status is more if the pain is advancing to chronic stage. The ones available usually, mostly they are in English language, but if your patient is not proficient in English language, then those that have been translated into the local language and culturally adapted can be used. It is good that you look for the tools that have been culturally adapted, because ordinary translation may not exactly capture what is needed in the tool. Then the outcome measures that you will use related to this pain, disability, function, and what have you, make sure that they are reliable and they are valid. They are reliable, they are valid, and they are maybe specific to the neck pain. So completion of the clinical examination. I think we should just move to the treatment now. So mostly, when we come to the treatment, the primary aim usually is to relieve pain. But sometimes when the patient comes, maybe the patient is in abnormal posture, cannot attain a normal posture, the neck maybe has to be twisted, have to be side bent, or whatever position. Then they want that posture to be corrected, or probably maybe there is stiffness in the neck, they cannot move to a certain range because the neck is stiff, maybe to relieve the stiffness, or there is disability, they are unable to perform certain functions, or it is affecting their sleep, so they want their sleep to improve. Like night is a nightmare for them. Whenever it is dark and they want to sleep, everybody is sleeping, but they are worried, they are in pain, and overall quality of life. So any of these can be an aim based on all the histories and the complaints you receive from the patient. So based on that, now you have to choose what you want to do. So irrespective of conditions we manage, the best model of treatment is evidence-based treatment. And this evidence-based treatment now for the neck pain, then we have to look for what is the best way to manage acute neck pain. So we use the combination of the three that are the standard for evidence-based intervention. In evidence-based intervention, you look for the best external evidence. So now for acute neck pain, what is the evidence saying regarding its treatment? Which interventions are the best based on the evidence? Then you now look at yourself, you the therapist. Are these interventions requiring any expertise? If they do not require any expertise, it means you can easily administer them. But if they require certain expertise, are you experienced enough to administer those interventions? Yes or no? Then the patient's preference. This patient that you want to manage with the neck pain, these are the available interventions. So you now give the patient all the explanations. This is beneficial, it can relieve this, it can relieve this, it can help this. And this is also equally beneficial in helping this and this, and then let the patient choose the best. Or you, the therapist, together with the patient, you should arrive at the best way to manage the patient. If I remove my charger. It's not. Yes, I think it's charging. It's charging. No, it's removed. Yes. So ideally now, for the acute neck pain, the therapist should be able to now look and see from the hierarchy of studies that can tell you which intervention is beneficial in the management of acute neck pain. You should look for systematic reviews and meta-analysis. If there are systematic reviews, and from their result, you can now see certain interventions that are recommended and certain interventions that are not recommended, that is the best. If you are unable to get that, then you move down the hierarchy to randomized control trials. But because neck pain is something very common, it has huge burden, then we should be able to see systematic reviews and RCT. So we shouldn't even be thinking of going to lower level of the hierarchy. And when you see the systematic reviews or the meta-analysis, and in some certain situations, maybe practice guidelines. If these practice guidelines also follow the procedure of systematic reviews, then you can now use the guidelines. And then you need to consider different things when you see the evidence. Now, probably maybe a systematic review regarding conservative management, for example, of acute neck pain. So at the end, what are they saying concerning the evidence? Is it strong, high, or excellent level of evidence, which you should always use for the management of your patient? But it's hard to find because of the scrutiny and the guides for studies to reach that level of strong, high, or excellent level of evidence. If you're unable to get interventions that are supported by high or strong level of evidence, then you should get interventions that are supported by moderate level of evidence. So in intervention, always strong level of evidence or moderate level of evidence are the ones that are used for managing patients. In some cases, weak or low level of evidence may be used if the high and moderate level evidence are not available, and perhaps this intervention maybe have not received adequate research. So the studies are not adequate enough to judge it to reach moderate or strong or other level of recommendation. When you get the study, be it a systematic review or practice guideline that says maybe there is strong or high level evidence or moderate level evidence, then that is not enough. Now you have gotten a study that is telling you there is certain level of evidence that you can trust. But this intervention, this level of evidence, high or moderate, on which outcome? You may come and see probably maybe there is high level of evidence that manual therapy is beneficial in acute neck pain, but they will say in improving quality of sleep. So it means that manual therapy is for quality of sleep. This patient that you just finished assessing, is the patient having issue with sleep? If the patient completely doesn't have issue with sleep, then it is not that level of evidence that you need for this type of patient, because the complaint the patient has is not the outcome supported by the evidence you have. So you have to now go and look for the evidence regarding the complaint of the patient. Maybe the patient's complaint is more of the pain. So it should be a study that is now telling you that this procedure is effective in improving pain intensity in acute neck pain. So this should be the guide for therapists when they are managing the patients. So when they see that, when you see that evidence, then you have to also come to that evidence and see how recent is the evidence. Probably maybe there is the systematic review or there is the guideline, but it has been in existence for many years. And probably maybe many studies have been conducted after that. And because of those many studies, probably that evidence that was mentioned in the previous study may not still be the existing level of evidence if recent studies are also integrated. So probably you have to look for more recent. Then how extensive is the evidence? Maybe the systematic review or the guideline is just limited to maybe Asia or Europe or somewhere, and your patients are probably maybe different, and you think that intervention that is reviewed in that region maybe is not the common intervention So I gave an example here with a systematic review. The effectiveness of conservative treatment for patients with cervical radiculopathy. So like I explained in the previous slide, that you have to look at the population that this level of evidence is talking about. So like in this one, is patients with cervical radiculopathy. So you have already examined your patient, and you have now realized that this patient has neck pain that is radiating. So this is the type of evidence that can guide you on the management of such patient. But if after examining that your patient, you realize this is a patient with acute neck pain, but there is no radiculopathy, then this evidence is not for your patient, because this is specific to patients with cervical radiculopathy. So we have to be very careful with the selection of the evidence. And in this evidence, from the results, so 15 articles were included that corresponded to 11 studies. 2 studies scored low risk of bias. There is low level evidence. So now this is where we come to the level of the evidence. So they are telling us there is low level of evidence that a COLA is no more effective than physiotherapy at short-term follow-up. So COLA is no more effective than physiotherapy. So given COLA doesn't help, but it is low-level evidence, not moderate, not high. In the absence of moderate and high, you use the recommendation of the low level, but in the presence of that, then you don't. Then there is low-level evidence that traction is no more effective than placebo traction. And often you will think of traction first when you want to manage your patient with radiculopathy. But I intentionally brought this so that I will bring subsequent evidence that were published after this. So we can see how evidence can be changing as more studies are being conducted in a field. That is why I said you have to check the evidence and see when was the evidence generated. How old is it? Is it the most recent or it is old? So I brought another study here, evidence for the management of cervical radiculopathy. So conservative management. And in this one, they said there is very low certainty evidence supporting the use of acupuncture, prednisolone, cervical manipulation, and low-level laser therapy for pain and disability in the immediate to short term. So we can see it is radiculopathy. That is the population. So only patients with neck pain that is radiated. It is, the level of evidence is also still low. But they are now telling us this low level evidence is supporting the use of acupuncture. So acupuncture can be used in radiculopathy. There is medication also, prednisolone. Then cervical manipulation. And then low level laser therapy. So if maybe as I am going forward, I now see a moderate level evidence, then I should drop low level evidence, because moderate level evidence is stronger than low level evidence regarding the interventions I am talking about. So now as I'm coming forward, I'm now having, now it is a clinical practice guideline published in 2017. 2017 is not that very old. So in this practical guideline for the clinicians, then they now divided the neck pain into different categories. Neck pain with mobility deficits. There is neck pain, and then the mobility of the patient in the neck is also impaired. So certain range is limited by pain or by stiffness or whatever. And then they now categorize them into acute, subacute, and chronic. So for the acute, clinicians should provide thoracic manipulation, a program of neck range of motion exercises, and scapulothoracic and upper extremity strengthening to enhance program endurance. So you'll be surprised that thoracic region and shoulder region are incorporated in the recommendation, because the muscles that act on the neck region, they also crosses to the shoulder and thoracic region. So isolating your exercises to only the neck region will not give you the best outcome. So the range of motion exercises are now recommended, and they have to cut across to the thoracic region and the shoulder region. So when patient is now complaining, my pain completely is in the neck region, why are you doing something to the thoracic region? So the therapist should be educated enough to give proper explanation to the patient, because in evidence-based practice, patients should be carried along. They should understand the concept of the treatment. Then clinicians may provide cervical manipulation and or mobilization. It's also recommended in the acute neck pain that has mobility deficits. Then for neck pain with radiating pain, they now have also a separate recommendation. And then the recommendation here is for patients with acute neck pain with radiating pain, clinicians may provide mobilizing and stabilizing exercises, laser therapy, and short-term use of cervical collar. And they target as short-term use. So it shouldn't be used for long-term. Then for neck pain with movement and coordination impairments, like in the whiplash and the rest. For acute one, for patients with acute neck pain with movement, coordination, or impairment, clinicians should provide the following: education of the patient should be educated on the do's and the don'ts. Then this should include return to normal, non-provocative, pre-accident activities as soon as possible. Those activities that they are now afraid because of the accident, because of the whiplash or whatever, they should be recommended to start getting back to them gradually. They shouldn't be afraid that these movements are going to aggravate their condition and make their pain worse. They should minimize use of cervical collar. Usually they get addicted to use of cervical collar, thinking it is the only protection. And the ideal protection is move the collar out, let the muscles be strong enough to protect the region, let them be active, while cervical collar is a passive protection. So you need an active protection, that is, the muscles should be strong to now protect the collar, the neck region. Perform postural and mobility exercises to decrease pain and increase range of motion. So these range of motion exercises, they have dual function based on the evidence. They relieve the pain, then they of acute neck pain. So this is evidence-based treatment recommendation for neck and low back pain across Europe, a systematic review of guidelines. So I intentionally brought this. This is in Europe, but if you look at any evidence, be it a systematic review or guideline regarding patient treatment, now we are talking about neck pain, then you look at those interventions. If the interventions are not culturally sensitive, then it means those interventions there will still be the type of interventions that can be given here. For example, exercise. Exercise, whether performed in Europe or in Asia or in Africa, is still exercise. Laser, whether performed there or in Kano or in America, is still laser. But if they have to do with cultural adaptation, for example, education, How are they educated there? Maybe internet was used. Maybe a link is provided. They have to now access the internet. They have to go through this, go through this. So internet accessibility is needed. Then literacy is needed for you to be able to read. And you think now the patients you have here, they may not have access to the internet. They may not be literate enough to read. Then in that, then you will now have to have interventions that are culturally sensitive to the region where you are practicing. So now we look at what they are recommending. And in this, they said for neck pain, there were consistent weak or moderate strength recommendation. So, and we said when you have moderate is always acceptable for you to use in the management of the patient. So there is weak. Your patient with neck pain, they need to be reassured that this is not something that they should be much worried about. Patients get better from it when they have such ailment. Then advice and education. So they should be advised to be active and they should be educated. So in this, it will make sense if you go through the evidence, which type of education was used. If the material used for educating them is not the type that can easily be used for educating them here, then you use what is culturally acceptable for educating your patients here. Then referral for exercise therapy programs is needed for the patients with the neck pain. Then topical medications, they are also found to have weak or moderate level evidence for the neck pain. Then plus psychological therapies or multidisciplinary treatment for specific subgroups. For the psychological therapy, they now say for specific subgroup. Those that from the pain, they have already started developing maybe fear avoidance, catastrophizing, all those psychological issues. If they, while subjectively examining them, they don't have such, then the psychological therapy is not meant for them. Only the subgroup that have developed that, then they are recommended to have such intervention. Then I also brought another guideline here, neck pain clinical practice guideline, a systematic review of the quality and quantity of complementary and alternative medicine recommendations that can be used for the patients. So there are the guidelines here, about 1, 2, 3, 4, 5, 6, 7, 8. So for these guidelines, now the first guideline is visible for all, yes? So the first guideline we can see, they didn't report on acupuncture. Then for exercise, it's a plus. And in the definition there, they said plus recommendation for the therapist's use. So exercise should be given. Manual therapy should be given. Massage therapy should be given. Manipulation should be given. Traction wasn't available. Ultrasound wasn't available. Yoga wasn't available. And that is in 2018, which among all the guidelines is the most recent. While the next guideline is 2017, acupuncture wasn't available, exercise is recommended, manual therapy is recommended, massage is not available in their own guideline, then manipulation and mobilization is available and recommended, traction is recommended. And then as we come down, we will continue to see acupuncture is recommended, but not as much as exercise, manual therapy, massage, ultrasound is recommended in another guideline in two guidelines, 2017 and 2016. Yoga is recommended in 2016 and 2000. Both the studies were conducted in 2016. And for all this, we can see subsequent guidelines, those interventions were not reported because they were not available. So you can still go ahead and use them for managing patients with the neck pain. The only way you will not use recommendation is when there is a recommendation that is saying you use it, and another one is saying don't use it. Like, for example, the traction. the guideline for 2017 said you can use the traction. Then we have another guideline in 2016, which is just a year apart. It's saying you should not use it. And then another guideline in 2016 is saying it's indifferent. Using it and not using it, no difference. So you can see traction is not much supported by the evidence, while exercise is supported. And then when we come to the exercise, usually many therapists, they think when exercise is mentioned, it's only neck exercise. We often see our therapists, when they manage patients with neck pain, all the exercises are for the neck. And probably maybe when your patient comes with neck pain and you now give that patient aerobic exercises, the patient may even complain to you that I came for neck pain. Why are you giving me exercises for lower limbs? You are asking me to ride a bicycle. So which type of exercises should we give these individuals? Probably maybe our participants online. Which type of exercises? Now, exercises are recommended. Which type?
Mobilization exercises.
Okay, if it is mobilization exercises, they will fall under manual therapy and mobilization. So we are coming to them. When they mention exercise, they mean active movements. So which type do we give the patients?
Strengthening exercise. Like resisted exercise. Yes.
So if during the examination, we have passed through the examination, if you have noticed there are weaknesses around the neck region, yes, you can give strengthening exercises. But if there is none, exercise is meant to be for the whole body. When the body is exercising, and at that time, then the so-called happy hormones, then they will be released more into the blood. Then they will now suppress the release of the nociception, and then the pain intensity will reduce, and then individuals' function and disability will improve. So if your patient is not very understanding, you may still give some specific exercises to the neck, but overall exercises for the whole body. If the lower limb is exercising maybe by aerobics of cycling, still the effect in the blood and the release of those endorphins is still going to act on the neck region and the pain that is perceived in the neck. So seeing a patient put on aerobic exercises and the patient is only having neck pain is not a misnomer. It is normal and it is recommended, provided you are now giving your patient exercises to do. It is the overall effect of the exercises that makes the pain intensity to lower, and then disability improves. So manual therapy is highly recommended here in the guidelines. I can see 1, 2, 3, 4, 5, 6, 7. They are all recommending manual therapy, and no single one said manual therapy is not beneficial. So it means in the acute neck pain, we can now give manual therapy. But which type of manual therapy now do we give? Our participants, any suggestion?
Can I say something?
Yes.
Okay, I think the kind of manual therapy that we can give will be dependent on whether the pain is radiating to both upper limbs, maybe, or whether it's unilateral. If it is central or unilateral, it will determine the kind of manual therapy to give. If it is unilateral, mean that you might give a manual therapy that is targeting the transverse process or the facet joint of the affected area. Whereas if it is central, you target the spinal process of the affected vertebrae. That's what I think.
I totally agree with you. Yes. So For the manual therapy, still our previous discussion on the assessment, the examination. The time you examine the patient, if there are issues with the joints in the cervical region, as maybe you have done the accessory movements, the snags, and then the joint spaces are restricted in movement, and the pain, there are certain angles that they now adjust, and then the pain is better. So now you are giving manual therapy to the joints. But if during the examination, the joints have no issues, but the muscles, while examining manually on palpation, there are painful nodules, there are trigger points. Now the manual therapy you are going to give is manual therapy to the muscles. So probably maybe ischemic compression or positional release as they are administered to trigger points. While if there are compression also for the nerves, then manual therapy that increases the joint space and relieve compression of the nerves. So this is a general recommendation that manual therapy should be given, but it is your assessment that would have told you which structure is at fault. Then the manual therapy that is targeted to that structure at fault is what is recommended. So someone may manage the patient with neck pain and say manual therapy has been recommended, he has given manual therapy, the patient is not getting better. That probably is because during the examination, he has not been able to pinpoint which structures are at fault and then give the corresponding manual therapy for such structures. If muscular structures are the ones at fault, then manual therapy targeted to muscles should be the ones given. If muscles are at fault and you are given manual therapy that is targeted to intervertebral joints, then the patient will not get better because that manual therapy is not targeting to the structure at fault. I hope I am understood. Then massage. So also I can see in the recommendations 1, 2, 3, 4, 5, 6. But for massage, we obviously know massage is over the soft tissues. So it is the soft tissues around the neck region. When we manage the patients and we give that, then patients get better. And I think this is a common practice. We hardly manage patients with neck pain without giving massage. And then now the manipulation and mobilization. So this is a combination. You manipulate and you mobilize. It didn't say manipulation and or mobilization. It is the combination. You manipulate and you mobilize. And this is also equally recommended like exercise and like manual therapy. And manipulation and mobilization have to do with the joints and the segments. So if the joints in the intervertebral joints are affected, and probably maybe there is radiation and then upper limb is also implicated and then the brachial plexus, then manipulation that targets the joints and then the upper limb, they are combined. So in this, many of the chiropractors and osteopathic medicine also have evidence regarding the interventions they give. But for traction now, I have one guideline that is recommending traction, one guideline that is saying no traction, and then one is saying indifferent. So participants, should we give traction or not?
Can I say something, Prof?
Yes.
Okay. Based on what you said, the most recent guideline recommended that traction is not effective. And if we are to follow that, I think that the most recent guideline should be the position we should adopt. I think you quoted
Yes.
2018, 2017, and 2016. So
I cannot hear you well.
Okay, I am saying based on what you said, the most recent guideline that said that traction should not be used should be the one to consider. Since the 2016, I think was indifferent. 2017 say you should not use. We should do what the most recent guideline states.
we had issue with the network. So one of the participants was contributing. Can you continue?
Okay, sir. I was saying that we should be able to use what the most recent guidelines states. Like what you told us earlier on, that in 2016 was a bit indifferent. Then 2017 guidelines said that we should use. Then 2018 says there is no no positive outcome. So we should go by what the most recent guidelines states, which means that we should not use.
Hello?
Yes, sir. Did you hear me, Prof?
Yeah, now I can hear you. It was initially breaking.
Okay, I'm saying we should go by what the most recent guidelines stipulates.
Okay,
Which is
I like the idea, but we should always also be critical clinically. Yes, there is a guideline of 2017. We can see it here that is saying we use traction, and then a guideline of 2016 is saying we shouldn't use traction, and then another of 2016 is indifferent. 1 year is not significant. Last year and this year is not much significant because they are, if we want to call them recent, both are recent. If we want to call them old, both are old, because 1 year difference shouldn't make one recent and one old. But in this kind of situation, then a clinician should go into the individual guidelines and see which type of studies were used. Probably maybe the most recent guideline, if I may say, sometimes may just come and cover only the recently published studies that were not covered by the previous one, meaning that that study did not put in together all the studies. So it uses only the recent ones. So we have to look at the guidelines. How extensive are those guidelines? Which type of studies they have incorporated? And then it's the old one. That is one. And then secondly, if we have other interventions that we are not getting conflicting evidence, because this is what we call conflicting evidence. One evidence is saying you should use. Another evidence is saying you should not use. While we have consistent evidence regarding this same patient for acupuncture, for exercise, for manual therapy, for massage, for manipulation, and perhaps maybe ultrasound also here, then we should not go to conflicting evidence when we have consistent evidence that other interventions are very beneficial to the patient. So clinicians should be careful with this. We may fancy certain intervention, but if there are conflict in it while we have other interventions that have no conflict, they are straightforward and they are found to be beneficial, then we should give our patient the best. Then for ultrasound, we can see also here that there are studies of 2017 and 2016 that are in support of ultrasound, and we don't have other studies that are conflicting it. So we have evidence that also the use of ultrasound can now be used in the management of neck pain. The same thing also with yoga. So some of the interventions are directly towards the neck, while some are for the general body, where the effect of such intervention the neck is for the whole body, but ultrasound is specific to the neck. So where you have the pain, then ultrasound is given. But all this exercise, acupuncture, manual therapy, massage, manipulation, ultrasound, and yoga that are recommended, then the next part of the specifications in the guidelines. So for the acupuncture, these guidelines that are now saying acupuncture is recommended, what are the specifications? How many sessions of acupuncture should be used? How should the acupuncture be administered? So only if you have followed what the guideline says, then you can now say you are using the one supported by the evidence. The same thing with the exercise. How often should the exercise be administered? For how long, how many minutes, the duration, the frequency, the intensity. So only if you have used these specifications for that guideline, then you can now say you are using the evidence-based intervention for this your patient with neck pain. The same thing with also the manual therapy. Which types of manual therapy have been listed in these guidelines? How are they administered? How often are they administered? Then when you now use them, then you will now say, I am now using the evidence to manage this my patient with acute neck pain. So the same thing for the ultrasound. What are the parameters? Is it post ultrasound or continuous ultrasound? For how long? How frequent? Then you will now say you are using what is supported by the evidence. Then I brought another one, and this evidence-based recommendation for neck and low back pain across Europe. Also, it is telling us in the previous one we have seen reassurance, advice, and education is supported. So it is also supported here. Manual therapy plus other treatments supported by moderate evidence. In the just guideline that I just presented, manual therapy is supported by evidence. Exercise therapy alone or plus other programs supported by moderate evidence. And in the previous one also, we have realized that guideline is supporting exercise therapy for that. Psychological therapies for specific subgroups. And in the previous guidelines, we have also mentioned that only subgroups that have psychological issues related to the symptoms, maybe mood, persistent pain, psychological risks, they should benefit from that. Then thermotherapy, traction, electrotherapies, cervical orthosis, inconclusive. So if you have other interventions that consistently they are beneficial, you should go for them. You shouldn't go for interventions that are found to have inconsistent or inconclusive evidence. Then I brought one specific guideline here also. It is a global spine care initiative applying evidence-based guidelines on the non-invasive management of back and neck pain to low and middle income communities. Knowing that there are communities that some of the interventions may not be available in those communities, then sometimes experts can come up with guidelines for such communities that if you don't have this at your own level, the interventions you have that you can afford, these are what are beneficial. So clinicians should provide education, and which is supported by other guidelines, reassurance, advise patients to remain active. So inactivity, use of collar is not the best option, and provide information about self-care options. Not that all the time the patients have to come for interventions. And if it is a low resource setting, even the cost of transportation, and probably they have to leave their own job to come, and so they are less productive, and probably is this the job that gives them the daily meals. So self-care option is also highly recommended in low resource settings. So you have to look at your patients and see, are they the types that can afford coming regularly for the treatment, and it will not affect their income, and it will not affect their family issues? If it can, then self-care is supported in low resource settings. Then for acute neck pain without serious pathology, exercise is inexpensive. Manual therapy mostly is inexpensive, unless in private centers where maybe the therapists that will now administer the manual therapy maybe have special charges. They mentioned superficial heat here, but we have to be careful with which superficial heat gives that. We have realized ultrasound is beneficial, but in low resource setting, we are not sure if that will be available. Then non-steroidal anti-inflammatory drugs are beneficial, but usually this is not the field where we make the prescriptions. There is recommendation for patients with chronic pain, but that is not within the scope of this workshop. There is a specific workshop for the chronic pain. So we said evidence should be used in managing these patients, but we have other factors that influence clinical decisions and the use of the evidence. So good practice is responsive to a range of contextual factors, human resources. These interventions that are supported by evidence, if there are lack of human resources, then perhaps the therapist may not be able to administer them efficiently. Maybe I have mentioned that if it is exercise, there are specifications for how many minutes, how frequent, how this. But probably because of the human resource, only you or two of you are in the clinic and you're managing the patients, and the number of patients are much, that if you have to administer those exercises based on those specifications, then you will only see few patients while others will not receive treatment. So in that case, you have to use your own clinical decision. If exercise require much time, then probably maybe manual therapy, maybe only 1 or 2 sessions are given and patient gets better. Then you should go to other interventions that the human resource you have may permit you to use that evidence so that it can accommodate more patients. So it is up to the therapist now to clinically decide which evidence can accommodate the workload I have. The skills of the healthcare professional. Sometimes some of these interventions that are supported by evidence, they will require extra skills. So if you are not skillful in those interventions, then your patients will not benefit from them, even though they are supported by evidence. Then availability of the necessary items for effective intervention. That is why the immediate past guideline I mentioned is even for low resource setting. So in some places, there are enough resources, and in some places, the resources are lacking. So that has to be taken care of. The workload, which has to do with the human resource, then culture and religion. Sometimes some of the interventions, the way you want to administer them, maybe they are not supported by the culture or supported by the religion. And in evidence-based practice, then patient's preference is also integrated in the management. So you shouldn't be the alpha and omega in deciding for the patient what should be given to the patient. Tell them how beneficial they are, how they are supported by the evidence, and then collaboratively decide which one you give your patient. So the outcomes now. How do we now So how do we check the outcomes of our patients? Acute neck pain, we are managing them. How do we check the outcomes? Participants?
Participants,
are we together?
You can access the yes, sir. Hello. You can access the pain rate by using your some of the pain rating skills that we have. You can use your your number numeric the VAS. You can use the NPRS. You can use any of these pain relieving pain skills, I mean, to check if the is actually increasing or is decreasing, sir.
Hello, participants, are we together?
Yes, we are together.
Okay, so if we have chosen our treatment based on what we examined our patient for and realized this is the fault with our patient and administered intervention supported by the evidence, then how do we look up for improvement regarding the outcomes of our patients? Can I have some contributions?
Yes, sir. I was saying we could assess pain to know whether it is increasing or reducing by using the pain outcome measures such as the numeric pain rating scale, such as the visual analog scale. You can use any of those to assess if the patient is having less pain or more pain with the interventions.
Yes, excellent. So if at the time you finish assessing your patient, pain is one of the key concerns, then an outcome measurement of pain intensity, if it is intensity that is the issue, or frequency, how frequent it is per day, then whatever related to the pain need to be assessed, and then it need to be reassessed at intervals. So if pain intensity is your concern in the patient, the previous guidelines I mentioned, they will say, for example, exercise is beneficial for the neck pain treatment. Then look at that guideline, beneficial in neck pain treatment in which outcome? If it says disability, then only if your patient is having disability during assessment, then you should administer the exercise. But if they say pain, intensity, and disability, then patient with pain being disturbed by pain, or patient being disturbed by unable to do things, or patients being disturbed by both can now benefit from the exercise therapy. And then sometimes the outcomes in the evidence-based practice, maybe from the recommendations, they will tell you this is in the to improve further than that, then you can use this to achieve the short-term goals. Then you use the evidence that is also giving you results for long-term. So I use this to achieve short-term goals, then immediately I will switch to interventions that will give me long-term goals so that my patient will now benefit from both the short-term and the long-term goals. So all this need to be incorporated in the patient's clinical decision. So many things have to be looked up to. And this is my last slide. We had serious issue with the internet, so we were unable to go on smoothly, but I think we have discussed things that should be discussed to clinicians regarding acute neck pain, their assessment, and then treatment based on the evidence. If there are questions, I think I will entertain questions. We are supposed to finish by 5, so we have like 19 minutes to 5.
Yes, sir. I have a question, sir.
Okay.
Regarding the traction that we mentioned, based on the evidence,
yes,
like there's a 1-year gap as we saw. Supposing I have 2 patients and I decide to give one the same intervention, or the 2 of them the same intervention, and one reports that, okay, the traction really helped and reduced the pain and also improved the range of motion, for instance, while the other said no. Can I just continue with the traction for the person that's manual traction now? Can I continue with that patient that is comfortable and feel some relief with the traction, or I should discontinue because it's having a weak or no recommendation? So what do you have to say, sir?
Yes, there are individual differences among patients. And we have also one concept in the patient's management. Sometimes the concept of hands-off and hands-on. Sometimes some patients, they have this psychological belief that when interventions have to be, biologically attached and manually administered, they get better with them. So if they have such belief, and you have already, this one that you compared maybe 2 patients, which like maybe a case control, you have a case and then you have the one that controlled, this one received it, this one didn't receive it. You may say it is the traction that makes the patient a little better if the two patients are similar, except this traction that is making them different. For example, both patients are from the same gender. Both patients are within the same age group. Both patients are having similar pain intensity. Both patients are having similar treatment, except this one is having the addition of the traction. So if they are similar in all ramifications, it is this traction that is making them different. Then at the end, you may say, it seems for this particular patient, even though maybe traction is not well supported by evidence, there is individual difference that this patient is benefiting from the traction. They hope it is clear.
That is clear, understood. Thank you.
Okay.
So can I make some comments?
Yes.
Okay, thank you so much, sir, for this wonderful presentation. Okay, so you've actually spoken so much on evidence-based practice with respect to management of patient with acute neck pain. Now,
Yes.
for instance, we know that there are different pillars for evidence-based practice. One is the expert opinion or so, experience. The other one has to do with the expectation
Your
of the
network is
patient.
breaking.
Oh, can you hear me now?
Yeah,
Is
can
it
you come
better?
back? Because the network wasn't so clear.
Okay.
Yeah, I can hear you now.
Okay, I'm saying that based on evidence-based practice, that there are about 3 pillars. The other one that has to do with research, the other one with experience of the clinician, then the expectation of the patient. And now the guidelines which are developed, that we make references to, were actually developed outside our own setting. And the patient probably they used in their researches that gave birth to those guidelines we are not from our own setting. So how sure are we that applying those guidelines as developed over there will reproduce the same positive result as it in our own condition? That is my concern. Then if we feel that we may not have this. Hello? Wow. Hello?
The network is misbehaving. This is your last question. I'm not getting it.
Okay, maybe you can respond to the one I asked, sir, the first one.
Okay, so for the first one that you asked, yes, that is why also it is good for clinicians to know how to clinically appraise papers when they see them. So if you see a guideline regarding recommendation for interventions for patients, usually those guidelines, they will take into consideration other published studies. I gave example with guidelines, for example, in Europe. So they are specifically meant to be for European patients. If we don't have similar guidelines, for example, in Africa, for example, if our patients are now here in Africa. So we can now look at those guidelines in Europe and then see what they recommend and whether if those recommendations can hold water for our patients or not. For example, I gave example when I was discussing them. Interventions that have to do, for example, with electrotherapy, where maybe certain electrotherapy modalities are recommended. If such electrotherapy modalities are available, then for pain reduction, for example, I will not assume that a patient that has pain in Africa will not benefit from that electrotherapy because of his biological or cultural makeup, because this is an electrical machine. But if it is something that has to do with conceptualization, how a European conceptualize pain education, if I'm going to educate that patient in pain, may differ from how an African may conceptualize the pain regarding his culture, the religion, the beliefs. They are different with a European patient. So you have to look at the intervention that are being recommended. That is one. And also some guidelines, they may be developed in Europe, but they are not meant for Europe, or developed in America, but they are not meant for only Americans. Look through the studies that they used. You will see that they used studies that were published in Africa, in Asia. So this is a general guideline that available published studies, irrespective of where they were published, were now included to draw conclusions. So clinicians should be able to have the skill of appraising what they see and know if it is the best for their patient or not.
Thank you, sir.
Okay, thank you, sir. Are there more questions? So I think the admin will share the materials with the participants. So thank you very much for your time, for your patience with the internet. This is Nigerian Network.
Sir, you're welcome.
Yes.
Thank you for the presentation, sir.
Okay, you're welcome. So is it time to call it a day? You will not say that you have not seen my face throughout. So I'm opening because I'm having cold.
Oh, so sorry about that, sir. It's good to see your face. Thank you for your time, sir, and sharing your knowledge with us.
Okay, thank you very much. Oga Lighton.
It's nice seeing your face. Thanks for the presentation.
I didn't know that you are part of it. Thank you. Okay, there are questions? Okay, let me check. Okay, someone is asking if I can explain more on the physiological and accessory assessment. For physiological, the range of motions that is the patient able to actively and passively achieve those range or not? If they are limited, what is limiting them? Is it bony limitation, muscular limitation, ligamentous limitation? So that you will know what to address if you are to manage the patient. While accessory movements, they are not the movements that a patient can achieve on his own, but they are available passively. If a therapist is examining the patient, he'll be able to now administer such movements that may have to do with maybe twisting, with pressure, with oscillation. They are available, but they are not functional movements that a patient can personally execute them. They are usually used to stress and stretch other structures and see if they are at fault or not. So I think we will call it a day. Thank you very much, all of you, for joining us. We meet probably another time.
Thank you very much. Even though the network was very, very disturbing, but
yes,
we were able
the
to
network
make
was
it.
very unfriendly.
Thank you very much, sir. Thank you very much, sir. It's a wonderful experience, and I've learned much more now on neck pain assessments and clinical appraisal also for the treatment modalities.
Okay, thank you very much.
Thank you very much, sir.
I do hope I will get access to the slides and the recording.
Thank you very much, sir, for the presentation. Thank you for your patience also, and everything that you taught today. Really, we would really like to have access to the slides if it's possible. Thank you, sir.
Sorry, are we done? My network really went off, so I just came in. Are we done?
Yes. Yes, we are done.
All right, thank you. Bye.
So just await for the materials and certificates. They will be shared soon.
All right, thank you. I appreciate. Have a great weekend.
Thank you, sir. Bye-bye, sir.
Thank you all. Thank you for your patience.